Hi, I'm Tamara Paget, and I'll be presenting Case Study 51, Addison's Disease. This is for Nurse 711, Advanced Physiology and Pathophysiology. CK is a 48-year-old white woman who presents to her sister's primary care provider with loss of appetite, progressive fatigue, and mild nausea for the past 5 days. CK and her husband are visiting her sister in Wyoming for 2 weeks. They normally live in Texas, but she's not felt well enough to do any of the normal things that she usually likes to participate in, such as going for hikes, walking, bicycling. She's had some mild symptoms that are progressively getting worse. She has a past medical history of appendectomy. Her PPD turned positive about 10 years ago, but it was treated. And she has hypercholesteremia, which is treated with diet and exercise. She has a strong family history of autoimmune diseases. And oddly enough, her husband was diagnosed with Addison's disease last year. Addison's disease is also referred to as chronic primary adrenocortical insufficiency, which describes this disease perfectly. This insufficiency is caused by destruction or dysfunction of adrenocortical tissue. The clinical symptoms of Addison's disease are secondary to the decreased glucocorticoids, mineralocorticoids, androgens, and the symptoms vary based on patient. Bitterl is how you say his name, described Addison's disease as chameleon-like, masquerading under the guise of many other conditions. Therefore, the diagnosis is often missed for a long time, with approximately 60% of affected individuals seen by multiple healthcare professionals before being diagnosed. Symptoms can include weakness and fatigue, weight loss with a decreased appetite. In children, this can be diagnosed as failure to thrive, is often diagnosed as failure to thrive, and it can sometimes resemble anorexia. There's also orthostatic hypotension, tachycardia, skin and mucosal hyperpigmentation, nausea, vomiting, diarrhea, or recurrent abdominal pain. There can also be depression, decreased libido, and amenorrhea. And in some patients, only about 10 to 15%, though, patients do have a salt craving, which is one of the different signs and symptoms of Addison's disease that isn't popular with other disease processes. An infection of the adrenal gland used to be the most often cause of Addison's disease, with tuberculosis being the most common cause, until tuberculosis treatment and prevention became popular in the 50s. So after that, now autoimmunity is the most common cause. However, in children, genetic disorders account for a lot of the cases. Injury or surgery of the hypothalamus or pituitary gland and certain medications can also cause this disease process. The incidence is about 5 to 6 cases per million people per year. The prevalence is 40 to 110 cases per million persons, which is similar to European countries. Those numbers were for the US, and which is similar to the European countries. And also remember, this disease is associated with hyponatremia, which can cause serious symptoms, including nausea, vomiting, headache, confusion, loss of energy, drowsiness, fatigue, restlessness, and irritability. And when it progresses to severe, muscle weakness, spasms, cramps, seizures, and coma. This is a great picture of the adrenal gland. With Addison's disease, there's a gradual destruction of the outer layer of the adrenal glands. And if you have autoimmune Addison's disease, commonly referred to as AAD, this is from the immune system itself. If this destruction is being caused by tuberculosis, it causes calcification of those cells, and other disease processes can cause destruction or malfunction of those cells. But either way, whatever the disease process is, the result is the same. Today, the most common infections that cause this cell destruction include fungal infection and cytomegalovirus. The zona glomerulosa, which is the outer layer of the adrenal cortex, produces the hormones known as mineral corticoids. These mineral corticoids, specifically aldosterone, help maintain blood volume, blood pressure, and water and salt balance by directing the kidneys to retain sodium ions in water while excreting potassium and hydrogen ions, excuse me. Corticoids, specifically cortisol, are produced in the zona fascicula and the zona reticularis, the middle and innermost layers of the adrenal cortex. The zona reticularis also produces adrenal androgens. Adrenal androgen, dehydro, we're going to call this DHEA. It's dehydroepiandrosterone. I think is how you say that. Sorry. The most important function of this DHEA is to assist the body in managing stress, both physical and emotional. So because of this gradual decline in cell function, the disease process also has a gradual onset, leading to delay in diagnoses. Over time, enough cells either die or stop working, and this can lead to adrenal crisis if it is not detected. In adrenal crisis, the patient experiences severe nausea, vomiting, diarrhea, hypotension, and this can progress to shock if not treated with saline, because it also leads to hyponatremia and steroids. Adrenal crisis is often brought on by acute stress, such as infection, trauma, or emotional stress. So for CK is presenting subjective data. She does drink occasionally, but denies smoking or recreational drugs. She's lost weight, has some salt cravings. She's had some bouts of dizziness and fainting, generalized aches and pains, and those are all kind of very vague symptoms, which is why this disease is missed so often. But our key is this tanning of the skin. And in the case study, actually said like her areola is more darkly pigmented. The folds of her joints are more highly pigmented, things that aren't normally affected by sun. And then for her objective data, she clearly has some orthostatic hypotension happening. Her pulses aren't very strong. The abdominal CT did give us the clue that her adrenal glands have experienced some atrophy. She had a great lab workup. I will tell you just the abnormal values. Her hemoglobin, hematocrit, platelets, and red blood cells were all abnormal, which is interesting. It doesn't normally correlate very closely with Addison's disease, but it can. But also she has a history of percutaneous anemia. So is that just not being treated correctly? Our hallmark symptoms, though, are sodium level 126, severely low. Also, her cholesterol is a little bit high, but her glucose 55, that's severely low. It was a fasting draw, but that is much lower than would be normal. Slightly elevated eosinophils, but our two big dead giveaways that this is Addison's disease is that her cortisol level is 2.0, whereas normal is 6 to 23, and her ACTH, which is adrenocorticotropic hormone, that is 947, which is really high. Normal is 10 to 60. So the low sodium level is a hallmark of Addison's disease due to the aldosterone deficiency, which impairs the kidney's ability to retain sodium. Elevated potassium is another indicator, as aldosterone normally helps regulate potassium excretion. Significantly low cortisol is a direct indication of adrenal insufficiency, which is a defining feature of Addison's disease. Because the adrenal glands are not producing enough cortisol, the pituitary gland compensates by producing excessive ACTH in an attempt to stimulate the cortisol production. These values strongly point towards Addison's disease. The Christian advanced practice nurse plays a vital role in holistic management of a patient with Addison's disease, from initial diagnoses with a thorough history physical workup, lab work, imaging, and not brushing the patient off as having anxiety or fatigue due to a lack of sleep or not eating correctly. And then long-term management. Key responsibilities would include prescribing medication like corticosteroids such as hydrocortisone or prednisone to replace cortisol, and mineralocorticosteroids to replace aldosterone and to help regulate sodium and potassium balance. Also, educating the patient about their condition, preventing adrenal crisis, and coordinating care across healthcare providers to ensure the patient's health and safety. Also, providing spiritual care and comfort would be appropriate. The APRN proactive management helps the patient lead a stable and healthy life despite this chronic nature of this disease. In Addison's disease, the lack of aldosterone leads to sodium depletion, low blood volume, which prevents the body from effectively adjusting blood pressure when moving from lying to sitting. And also, the lack of cortisol reduces blood vessels' ability to constrict in response to movement. So, therefore, that's why the orthostatic hypotension happens. Shoddy nodes, refers to a small, firm, and scattered lymph nodes that feel like shotgun pellets. This happens because of the autoimmune nature, the chronic inflammation, and chronic immune activation. And so that's why the shoddy lymphedema happens. And then also for the percutaneous anemia, maybe, but it's not being treated by the vitamin B or by the vitamin B12 that the patient is currently taking. So is the Addison's disease actually causing just a reduced red blood cell production by decreasing erythropoietin levels and impairing the bone marrow's ability to produce red blood cells? Or do we just need to adjust the B12 dose? And here are my references. Please let me know if you have any questions or concerns, and I hope you learned a lot about Addison's disease in this presentation.